Good day, everyone. My name is Mike Hamilton, and I'm Medical Director here at ISMP Canada. Welcome to today, which I've designated Wednesday, May 29th, 2004, and it also happens to be the day of the Med Safety Exchange. We thank you for joining us. We know that you are really busy out there in the healthcare world, and we appreciate you taking some time to join us in the audience and learn from our presenters. We'll begin today with a land acknowledgement from our offices in Toronto, and I encourage you to reflect upon where you yourself work and reside. We acknowledge that we are hosted on the lands of the Mississaugas, of the Anishinaabe, the Haudenosaunee Confederacy, and the Wendat. We also recognize the enduring presence of all First Nations, Métis, and Inuit peoples. We are grateful to live, work, and play on this land, and we want to contribute to the implementation of the Truth and Reconciliation Commission's 8 healthcare-related calls to action. So this webinar is a production of ICP Canada and the Canadian Medication Incident Reporting and Prevention System, or CMIRPS, with contributions from all our partners and you, the audience. The Med Safety Exchange is presented on the Zoom webinar platform. You are automatically muted, your video is disabled, and the presentation part of this is being recorded, and it will be available on our website in a couple of weeks or so. Now, there are a few ways to participate, to make comments, and I see that some of you have started. From the Zoom toolbar is typically at the bottom or top of your screen. If you use the chat panel, that's open to introduce yourself, to ask some questions or make some comments. All of those entries in the chat panel will be visible to the audience. If you select the Q&A tool, a window will open up and you'll have the option to submit anonymously through that if you so wish. Your responses will appear in the Q&A panel after they are answered. And please email us at medsafetyexchange@ismpcanada.ca for any questions we don't get to, and we'll try to answer them offline. And once again, there'll be an evaluation poll at the end of the session, and we encourage you to provide any feedback you like. We have a very great webinar planned today centered around the high alert medication list. Some of you will know we published the first Canadian high alert medication list back in February, and we've had terrific feedback and learning out of that, out of your comments, out of your questions. And we are thrilled today to be able to hear from some practitioners in community pharmacy, long-term care, acute care about how they think about how they use the high alert list and some of the ideas and strategies that they use in implementing a high alert program in their own sector and organization. And we'll also hear quickly about a collaborative effort resulting in an updated best possible medication history interview guide in both French and English. And time permitting, we'll have a short Q&A session at the end. So as an introduction to today's episode, we'll start with an overview of the Canadian High Alert Medication List. High alert medications are medications that have a higher risk of causing significant harm when they're used in error. And please recognize that these are not necessarily more likely to be involved in an error incident, but when such errors and incidents do occur, the consequences are often much more severe. And recognize too that you're often using these medications in such scenarios as emergency rooms, operating rooms, the back of an ambulance. You may be using them in the high alert populations that you serve, neonates, elderly, vulnerable individuals. So high alert medications, high alert situations, high risk populations often coexist, and this serves to compound any risk that's available or that's present. Now, having said that, high alert drugs are used effectively and safely the vast majority of the time. And it's really a testament to practitioners of any sort and to the processes we've developed that we can deliver these medications that often have very dramatic, profound, and immediate effects, that we can deliver them safely. And it's important to realize too that medications that are not considered high alert list are often also involved in harm, and some of that can be serious. So in February of this year, after an extensive process involving input and reflection from many individuals and organizations across Canada, we published the Canadian High Alert Medication List. This list is hopefully applicable in all sectors of healthcare: acute care, long-term care, community pharmacies, home care, residential care, outpatient clinics. But importantly, lists like this only take into account a general approach to healthcare delivery. There are elements in your own organization, elements of your medication management system that cannot be taken into account by this general list. There are medications in here that you may not use. There are medications in here that are a risk in your own organization that are not on this list. There are specific processes that you have. There are care services that you provide in populations you serve that create vulnerabilities that cannot be captured on such a general list. And for all of these reasons, we strongly encourage you to create your own list. We really want you to take the list we've created and build your own organization-specific list out of that. And when you've created your list, remember that the list is only a list. It's only a starting point for your organization and medication safety. The list doesn't do anything by itself. And frankly, as Angry Homer here attests, it is somewhat of a waste of time to make a list unless you also commit to some enhanced safety strategies for each and every drug on that list. You should have a safe, effective, reliable medication management system for all medications. But here you've identified drugs that you believe deserve even more attention. They are such characteristics as to warrant an even greater level of safety. Now, the upcoming presentations will outline how organizations in various sectors use this list and this approach to safety to implement their own high alert medication programs in their own organizations. And we'll now ask our first speaker to unmute themselves and present a perspective from acute care.
Thanks, Mike. And thanks, ISMP, for providing us with the opportunity to share an acute care perspective of the Canadian High Alert Medication List. Just like to take a pause here to acknowledge Niagara Health's Indigenous land acknowledgement as shown here on the screen. And thank you to everyone for acknowledging your land acknowledgement in the chat as I've been seeing those pop up. So today we're going to review an acute care hospital's evolving approach to high alert medications, along with the layering effect of system safety strategies, and further understand how Canadian high alert medication lists can be localized to an acute care hospital. So as you heard Mike talk about the high alert medication definition, and you're going to hear throughout different presentations today, these two definitions are really important. So I would like to just go over them again, just so that everyone has an understanding of why we're here today. So high alert medication is a medication that bears a heightened risk of causing significant harm when used in error. And by used, what we mean is any stage in the medication use process. So from procurement to prescribing, all the way out to monitoring a patient that has been administered a high alert medication. And then in terms of the high alert medication list, the list supports the identification of medications that require additional safeguards to reduce that risk of error and the type of patient harm that may happen. The list is intended to assist care organizations in developing their own localized organization-specific high alert medication list, and we're going to go through that together today. So you may be asking, who is Niagara Health? And for those of you that don't know, Niagara Health is a regional hospital system We are made up of 5 individual sites, and we do provide a full range of acute care hospital services to over 450,000 residents across the Niagara region. Our team is made up of 7,300 employees, physicians, volunteers, and we have quite a large patient partner program. We do pride ourselves on our accredited with exemplary standing, and this is just our demonstration of our team's commitment to achieving the highest safety and quality standards. So our journey has been quite long in terms of the approach to our high alert medications. It has developed across the hierarchy of effectiveness from both person to system-based strategies. And really this approach has happened as we have gone through digital transformations. And what I mean by that, from an example standpoint, would be implementation of smart pumps. And as we know, our strategies are only as effective as how much we evaluate those. And at Niagara Health, we have quite a robust continuous quality improvement process. And you'll see as we go through the different slides what this journey has looked like in terms of examples of these different base strategies. But how did we start? Well, we looked to what was in the literature as well as to what best practice standards were available to us at the time. And really, we started with what Accreditation Canada had defined as what a high alert medication was and what you needed to do to develop a high alert medication list. We also looked to ISMP in the United States, and we looked at what lists were available then, as well as what targeted best practices could be implemented, along with self-assessments for these high alert medications. And this really put Niagara Health on their journey for developing their first high alert medication list, which started in 2013. So it's hard to believe that that was 11 years ago. I was working in medication safety at the time, and was present when we did develop that list. So our strategies at that time were very much surrounded by rules and policy, education, simplification. And so we had 2 supporting policies to the first development of that list. One was defining what is a high alert medication, and the other was to support independent double checks of select high alert medications. We did have some paper order sets at that time, which helped in terms of the standardization of prescribing of some of the select high alert medications. But really, we were down on those person-based strategies in 2013. As we move along our journey, we were able to implement a few more strategies in terms of standardization, reminders, and redundancies with our first implementation of smart pumps, which allowed for standardization of prescribing practices along with administration practices of our laboring patients and surgical patients with epidurals, as well as surgical PCA and palliative PCA. We took the opportunity at that time to look at our automated dispensing cabinets and see what improvements we could make from the way that the medications were built in those cabinets from a nomenclature standpoint, so ensuring that we aligned all our tall man lettering with all of our packaging, as well as utilizing any pop-up alerts that could help with the end user dispensing process. 2016 to 2019, we started to do a little bit more of automation and computerization, still along the standardization, where we took those paper order sets and actually embedded them into an electronic order set system, which allowed for less deviation from prescribing practices. And we embarked along our second journey of smart pump infusion implementation with large volume pumps. And when we did that, we looked at some additional high alert medications to see which we could benefit from standardization of documentation records, which we'll go through an example in a moment. 2020 to 2023, I think everyone on the call can acknowledge that that was the global pandemic time. And during that unpredictability, we actually found stability in creating a medication safety working group. We have a clinical nurse specialist in medication safety. We have a medication safety pharmacist, directors of pharmacy, directors of nursing practice. And so that working group is really, it's the cornerstone of a lot of our safety strategies now, just getting that subject matter expertise when you're looking at the different stages of the med use process. So in 2020, we also looked at the replacement of our current automated dispensing cabinets with a new vendor. And with that, we welcomed some additional features which allowed some increased barcoding capabilities. It also allowed us to prevent the loading or assignment of medications that should never be in a patient care area. And now, here we are, 2024. We are now completing the current state analysis of the Canadian High Alert List that was just launched, and we are getting a new hospital information system, which will allow for some additional force functioning features, which is more your system-based strategies. So here is how we summarize everything in terms of our safety strategies for our different high alert medications at Niagara Health. Our Pharmacy and Therapeutics Committee oversees all the safety strategies. And then we have our supporting committees, like I mentioned, our Medication Safety Working Group. We have an Infusion Pump Committee, Order Set Approval Committee, Nursing Advisory Committee, and these all work together to bring up the information to Pharmacy and Therapeutics, which drives our safety strategy. We have one of these types of charts for every high alert medication on our list, and it goes through all of the same types of safety strategies that may be applicable to the high alert medication that we are reviewing. So for example, a standardized concentration, automated dispensing cabinet locations the medication can be in, if there's any required auxiliary labels or independent double check, it's all outlined there for our frontline staff. So if you're a visualizer, like me, you like to see what things look like. So here I'm just showing some of that electronic order set that I had mentioned that we had done in 2016. And we have 3 different order sets for heparin. This is the example that I'm showing. And on the right-hand side, you'll see that our pump programming actually aligns with the order sets, which helps guide the end user when they're programming this high alert medication. And we have 1 standard concentration that we use for heparin. I mentioned about standardized documentation records, and you can see that here on an upcoming slide. But first, we'll talk about the pop-up alert that the end user will see when they go to dispense the medication from the automated dispensing cabinet. So this was one of the new features that we had when we did the replacement of those cabinets. And we now have the ability to stop the dispensing process if the end user identifies it's an incorrect medication. So number 1, they're alerted with what they need to do, which is an independent double check, but they have the ability to actually stop dispensing by hitting skip and not dispense the medication, and it cancels the transaction. And they weren't able to do this with our previous automated dispensing cabinets that we had prior to that replacement that I mentioned. Here's an example of the documentation record that our nursing partners use for heparin, and it again aligns with our order set that you can see in the top left, where we have standard dose, low dose, and that again aligns with the pump programming. So again, trying to standardize and simplify as much as possible for this high alert medication. So that leads us to the 2024, where we now are doing a current state analysis between our high alert list and the Canadian High Alert List, which I have a University of Waterloo School of Pharmacy co-op student doing that. Once we had done that, we were able to then take that information and compare what we identified as any gaps in terms of what we have on our high alert list with what was on the Canadian High Alert List, and determine if there's any opportunity there with medications that are on our Niagara Health formulary. We took that further and we looked at incident reports of those medications in our incident reporting system over the past 4 years to see if there were any reports that were voluntarily reported for those medications. And then we also looked at if these medications could be programmed on a smart pump to see if there were any alerts that were alerting on a smart pump to identify if we had some opportunity there to look at the hard or soft limits that were built into the pump and make any adjustments. And that whole process is assessing the efficacy of the system safety strategies that we have in place. And so we'll talk about an example when we go through what we identified from that current state analysis. So on the left, you can see Niagara Health's high alert list, and on the right are the applicable categories that match to Niagara Health's high alert list. So the boxes in red are the medications or medication classes that are not on Niagara Health's high alert list. And so you can see there's some opportunity to review inhaled anesthetic agents, as well as sterile water for injection, 1 liter bags, and then dextrose at concentrations greater than 20%. And then on this next slide here, there are 2 categories within the medications with profound cardiovascular effect, and then 2 with the medications for specific circumstances. And so what we did first is we're going to go through the vasoconstricting medications, and we're going to go through an example of vasopressin. So if we align vasopressin back to that little map that I just showed, our current state analysis identified that intravenous vasoconstricting medications are not on the Niagara Health High Alert list. One of the medications within that category would be vasopressin, 20 units per 1 ml injection on the Niagara Health medication formulary. We reviewed for medication incidents that were reported to the Niagara Health IRS system, and there were no reported incidents. So then we looked at how this medication is prescribed and programmed into our Baxter large volume infusion pumps. And we actually identified some hard limit attempts by the end user. And we're going to show you what is actually happening at that level that we might be able to have some opportunity for improvement. If we think back to that heparin chart that I showed you, we do have restricted storage locations for vasopressin. We have electronic order sets with predefined prescribing rates. We have a standardized concentration, and we have hard limits in the pump already. So we do have some safety strategies that we would recommend for a medication being added already in place for vasopressin. So when you look at the prescriber order set for vasopressin, in the box in red, there's 2 prescribing rates that can be ordered for this medication. And the standard concentration is 20 units per 200 ml. And so what's happening is the end user is attempting to enter the incorrect dosing modifiers, which we call in the pump. And so you can select units per hour or units per minute in your first pump screen that you see on the right-hand side. And so they're attempting to put 2.4 units per minute in the incorrect dosing modifier when that should actually be units per hour. And so when you start to look at why that might happen, you can start to think about a few different things, and that they may be selecting with where it comes in the list categories based off of where it is on the order set. And so this has given us some opportunity to review whether or not we should be listing 2 different rates of administration on the order set. So that's what we're going to be looking at as part of our review. And so if we go back to this map here, this is where we would then determine what is the efficacy of our system strategy. So the hard limit prevents the end user from programming that incorrect rate, which is good, but we don't want to keep having end users do that and then contribute to alert fatigue. And so we'll present those findings next to our Med Safety Working Group and then applicable subcommittees, and then determine if we should actually add this medication to our high alert medication list. So in summary, as you can see from this abbreviated presentation on high alert medications for acute care, the development, implementation, and monitoring of high alert medications in acute care is a dynamic process as organizations continue to evolve. And you really need to collaborate with subject matter experts that are involved in each stage of the med use process, because this really leads to a more effective safety strategy and idea generation. An organization's high alert list truly increases in efficacy at harm reduction as it becomes localized to your organization's medication use patterns, and then ensuring that there's an ongoing evaluation of those targeted safety strategies. Thank you.
Thank you for that great presentation of a very sort of process, like a very standardized process of reviewing this, very structured. And I think that's a really great example. And I really appreciated how you emphasize how dynamic and responsive the whole process is. You need to identify, implement, evaluate, and change over time. The list is not static, and your approaches to high alert meds are not static, and that really comes out here. So thank you. And now I will ask our long-term care clinician, our representative, to hear about the perspective in long-term care.
Thank you so much, Mike. My name is Shirley Drever. I'm the clinical medication safety pharmacist for Sienna Senior Living. We're a group of long-term care communities in Ontario and British Columbia. I'd like to share with you today the measures we utilize in long-term care to keep our residents safe when using high alert medication. As a team who cares for seniors and other vulnerable populations, we're dedicated to putting checks and balances in place to ensure our residents are safe and have an engaging place to call home. Our purpose statement is to cultivate happiness in daily life, including the kind of happiness that can come from feeling safe. Our work is underpinned by a culture of safety, quality clinical care, and service excellence. When the new high alert medication list was released by ISMB Canada, in conjunction with our pharmacy partners, we completed a review of what stayed the same and where we needed to have a new focus. Anticoagulants, insulin, opioids, and cytotoxic medications with special attention to methotrexate were already on our radar for requiring extra steps to ensure safe administration, including independent double checks and packaging and labeling requirements. We have a robust incident analysis program that drives continuous improvement in the handling of medications, in particular high alert medications where the risk of harm is increased. New to this list were injectable or depot medications with long-acting effects. A particular note for the demographic we care for was the Prolia injection, as this medication is used in a high percentage of our residents to treat osteoporosis. In addition, injectable benzodiazepines were noted on the list. These medications are frequently used for both seizure control as well as end-of-life care in long-term care. New methods of augmenting the safe handling of these medications are being explored, including the possibility of initiating independent double checks and enhanced labeling. Communication of these changes to our frontline team members occurred earlier this year via virtual team meetings and printed materials. Our clinical care partners who visit the communities regularly review medication handling as part of their scheduled visits. So the high alert medication information is being reinforced by them. I would like to share some of the particulars surrounding the safeguards we have in place when handling high alert medications. They include additional packaging and labeling requirements, as well as independent double checks and self-verification. So let's start with packaging. We've endeavored to embed extra safety measures in our medication administration process to aid in the accurate administration of high alert medications. Each pouch containing high alert medication has a designation printed on the pouch that the medication contained within it is high alert. As you can see here, although this is a high alert jelly bean. This helps the nurse to differentiate this medication and alerts them to the increased risk during administration. This step, which is embedded in our administration process, calls out the importance of safe administration and reminds the nurse to call to mind possible side effects they are looking for. On the EMR, high alert is printed in the directions to alert the nurse to the care required. Some high alert medications are further identified by placing them in a pouch on their own to draw more attention to them. For example, warfarin. This enhanced packaging alerts the nurse to confirm the package dose with the original order in the chart for medications that change dose frequently. Lastly, medications like methotrexate are packaged outside the weekly medication strip in a separate blister pack. These 7-day packs designate the day of administration, for example, Wednesday, and have the entire methotrexate dose packaged in the Wednesday blister. This helps to ensure the once weekly administration of the entire dose. Independent double checks are used in long-term care for select high alert medications. The success of an independent double check depends on ensuring that the check by the second team member is completely independent of the first, such that no biases are passed along. For example, you cannot say, please check this 2 milligram dose of injectable hydromorphone for me. You must actually rephrase it as, please double check this injectable for me, so as to not pass along any information that might impart bias to the second check. Comparison to the original order is a key component, as well as a thorough technical and therapeutic check being completed during the independent double check process. An independent double check is performed on all insulins and documented on an EMAR. Due to limitations of our EMAR system, all other independent double checks must be documented using progress notes. Each home has a specific list of high alert medications where they perform independent double checks, mainly driven by policy and based on historical data from medication incident analyses. There are circumstances in long-term care where a nurse may have to perform a self-verification. During this self-verification, the medication is checked by the nurse. The nurse safely stores the labeled medication in the locked medication cart. They perform another unrelated task, and then they come back to the cart and recheck everything. They use 2 resident identifiers in the medication administration process. These are some examples of enhanced labeling of high alert medications used in long-term care. In the pharmacy software, the directions for methotrexate are auto-populated in the direction line to read once weekly. This helps to minimize order entry errors. Tall man lettering is used for all medications, including high alert medications. Tall man lettering can help to differentiate look-alike, sound-alike medications by emphasizing certain parts of the medication name to highlight the differences. The pouch porters, or medication bins that hold the medication strips in the cart, are labeled with high alert stickers to draw attention to the fact that this resident is taking a high alert medication, as pictured for Sally Smith on the slide. We include the resident's picture on the pouch porters to help in resident identification. Lastly, high alert auxiliary labels are used on strips and cards containing high alert medications. For example, the 7-day blister packs for methotrexate, the Prolia or Ozempic packaging. These are some of my lessons learned regarding high alert medications over my tenure working in long-term care. It's important for the nursing team to be aware of common side effects of high alert medications. With this knowledge, they are armed with the information to detect errors with high alert medications quickly. Some examples include awareness of possible hypoglycemic reactions with insulins and insulin secretagogues, bruising and bleeding episodes with anticoagulants, and mouth sores with antineoplastics. Secondly, ensure all team members administering medications understand the proper handling of hazardous and cytotoxic medications for their own safety. For example, crushing of cytotoxic hazardous medications for residents unable to swallow the medication is not permitted. For example, methotrexate. Proper measures must be taken to protect team members from administration to excretion of the drug. Pharmacists play an important role in finding solutions for residents with swallowing concerns. Next, identify look-alike, sound-alike medications early using a proactive risk assessment when new drugs are used in the home. So whenever a new drug is introduced into the home, We do a proactive assessment as to whether it is a drug that looks alike or sounds alike other medications that are currently being used, and try to anticipate whether this could cause an incident in the future. Having a standardized stepwise approach to order processing that ensures all the checks and balances are in place when new orders for high alert medications are received. This includes a standardized stepwise approach for nursing check 1, nursing check 2, making sure that the original order is compared to the medication when it does arrive at the home. And lastly, never stop learning and improving your processes to keep residents safe and happy. And I think that's it. Thank you so much for having me, Mike, and thanks to ISMP Canada and Sienna for giving me this opportunity. Thank you so much.
Well, thank you. And I think it's under-recognized how complex the delivery of medications is in long-term care. You're effectively implementing all these programs, these high alert lists, in someone's home environment where they live. And it's very clear how you center the resident and patient and the families in your planning and implementation. I mean, everything we do for those that we're caring for. So there are over 10,000 community pharmacies in Canada, and they're really a critical place of care for patients. And we welcome our next speaker to give us the community pharmacy perspective on high alert medications.
Great. Thanks, Michael. Hello, everyone. My name is Ina Ajala, and I'm the Director of Community Pharmacy Reporting and Learning Programs here at ISMP Canada. I'm also a community pharmacist. Next slide, please. Today, I'll talk about high alert medications from the perspective of a community pharmacy and why it is important in this context. We'll take a look at our medication safety self-assessment tool to understand how it can help reduce risks associated with high alert medications. And then to close it off, I'll share some examples of system safeguards that I implemented in my pharmacy as a pharmacy manager. Next slide, please. It was sometimes asked of me, why do we need a pharmacy-specific high alert list? After all, we're trained pharmacists. We know all about the risks associated with medications. It's our job. When asked this question, I always go back to the definition, which we've talked about a few times in some of the previous presentations today. High alert medications are medications that have an increased risk of causing significant patient harm when they are used in error. Thus, creating a pharmacy-specific high alert list is not about what we know as pharmacists. It is about ensuring the system is designed to prioritize patient safety. There is a growing recognition that pharmacists' roles are changing with expanded scope and increasing workloads. Workload and interruptions are noted in the most recent National Incident Data Repository safety briefs as being in the top 5 contributing factors for reports of incidents. If we can create system safeguards to reduce the frequency of these contributing factors, then we can reduce the risk of patient harm. Next slide. So how do we, as community pharmacists, create our own pharmacy-specific high alert medication list? The Canadian High Alert Medication List, developed by ISMP Canada, is a good place to start. In my previous role as a pharmacy manager, we created a committee of the staff pharmacists and registered technicians working at the pharmacy to establish the list. We considered our patient population, and we identified medications that we did not dispense and excluded them. We also considered medications that were not on the list, but were unique to the services that we provided to our patients. So how did we decide what was important to include? We used the Medication Safety Self-Assessment, or MSSA tool. Next slide. The Medication Safety Self-Assessment for community pharmacy is a tool that helped us to identify vulnerabilities or gaps in our workflow. In our case, It helped us to identify medications that were not on the high alert list. These medications were dispensed often in higher frequencies and had the potential to cause harm. The MSSA helped us to develop and customize our quality improvement plans, and very importantly, helped us to measure our progress over time. The MSSA highlights considerations for selected high alert medications and classes, shown here. The self-assessment process was very critical in helping us to identify which medications to include in our own high alert list. Next slide. A recent quantitative analysis of aggregate MSSA community pharmacy data revealed many of the items scored the lowest average scores were related to high alert medications. In this recent MSSA data spotlight, aggregate assessment scores related to high alert medications are shared along with improvement strategies for community pharmacies. Learning about barriers or challenges in other community pharmacies can be helpful in understanding if the same potential exists in our own pharmacy and in our own workflows. With this knowledge, and by sharing actionable evidence-informed recommendations with each other, we can reduce preventable harm-related incidents to medications. Next slide. Once your pharmacy-specific high alert list has been compiled by your local pharmacy committee, identify the lower scoring core characteristics and assessment items. The MSSA Data Spotlight outlines 6 steps for quality improvement and links to an action plan template. Use the hierarchy of effectiveness to develop improvement strategies that will work with your pharmacy's workflow. This action plan template links to the hierarchy of effectiveness, which was shared earlier in today's presentation. Record your team's recommended actions and monitor your progress over time. In the spirit of sharing and learning from others, I'll share some examples of system safeguards and strategies that my pharmacy team had used to help reduce the risk of patient harm from high alert medications. Using various options in the pharmacy management software, alerts or messages can be created for drug products. These alerts can be pushed down either from a central office in a more corporate setting, or they can be created locally at the pharmacy if permissions allow. Alert messages can also be printed and distributed to the patient as additional drug information. Adding the term high alert in the drug name field, so it appeared on the prescription vial or blister pack label, helped provide a reminder to the pharmacist or registered technician during the prescription checking stage. It also helped to support patient awareness and education, as it would often prompt the patient to ask, "What does high alert mean on the label?" Taking every opportunity to provide patients with education about their medication was our goal. This meant ensuring we created high alert signals in different ways at different points. We were able to customize the counseling information sheet to include the high alert terminology. Our pharmacists would use the counseling sheet like a checklist to ensure they covered all the important information. A signal for the patient was the high alert auxiliary label on the prescription packaging. A bright red label on the packaging was a good prompt for discussion. During counseling, a pharmacist might say to the patient, "You might have noticed this bright red sticker with the term high alert medication," and then proceed to discuss the specifics of the medication. Next slide, please. Creating reminders and checks in our busy pharmacy was extremely helpful. Placing a poster on our fridge which classified the different insulins by rapid acting, short acting, intermediate, or long acting was a quick and easy check when retrieving the inventory out of the fridge. When taking insulin out of the fridge, you could then quickly confirm if your product selection made sense. The poster also included the onset to action and duration of action. Another example was our opioid dispensing log documentation. We created customized logs that prompted the dispensing pharmacist to confirm the previous day's dose before administration. This would help with any dose adjustments needed to previous missed doses. and the customized dispensing log documentation included a copy of the original prescription from the prescriber. This allowed the pharmacist to confirm the dose back to the original prescription prior to administration versus confirming to the prescription label. This was critical in ensuring that if an error was made, it was less likely to be perpetuated. Due to our location, our pharmacy received many prescriptions for compounded medications. To ensure patients were able to receive their medications, we outsourced these compounded medications to a specialty compounding pharmacy. When we would receive the product from the specialty pharmacy, we had no way of verifying the contents of what we were dispensing. Although it was already signed off by a pharmacist at the specialty pharmacy, it left us feeling like we had not done our due diligence. Thus, we asked the specialty pharmacy to provide us with a copy of the compounding worksheet and the master formulation. Although that still did not allow us to verify the actual ingredients weighed, we could do an independent double check on the master formulation and the calculations. The documentation also included the weights of the ingredients signed off by the pharmacist or technician at the compounding pharmacy. Staff education is an important piece of the puzzle. It helps them understand the why for the implementation of these safeguards. For our regular staff meetings, the pharmacist would take turns presenting information related to a high alert medication or a risky process. Often, the pharmacy assistants would come up with the most effective safeguards as they were involved in many of the steps in the dispensing process. These safety discussions helped to engage the staff and allowed everyone to contribute to the collective goal of patient safety. Another method of sharing information with my staff was a monthly Did You Know poster for the staff communication board. Each month, I would share different information such as stats on dispensing, new drug information, and safety bulletins. It was a quick read and often prompted further questions or discussions from staff. Ultimately, it was a great conversation starter to start talking about high alert medications in your pharmacy. Thank you, everyone.
Thank you very much. It's clear that there are enormous opportunities in community pharmacy, but I see there's lots of great resources also being developed for continuous quality improvement. So now just an important update from ISMP Canada. ISMP Canada and in collaboration with Jerry MedRisk are pleased to announce the launch of the newly updated Best Possible Medication History Interview Guide. And these are available in both English and French. And this resource was originally developed way back in 2009 to help healthcare providers go through key steps in establishing a complete medication history interview at transitions of care. And this updated guide, developed through the collaborative approach, captures new evidence and feedback from healthcare providers and patients. And the guide has been modified with brand new questions and brand new prompts to assist healthcare providers when conducting comprehensive and accurate medication histories. And these include questions such as the use of cannabis, traditional medicines, vaccinations, and lifestyle choices. In fact, these are factors that really are increasingly recognized as important for the safe use of medications. Now we have a few minutes remaining that we can get to a few of the questions. We've had a tremendously busy chat box and Q&A. We unfortunately won't be able to get to them all, but really appreciate your engagement. We will send these off to the presenters and hopefully get you some back as we can. If there's something that you don't get answered, please send us an email at medsafetyexchange.ca and we can respond to as possible. So I'd like to start maybe with our representative from long-term care, if you want to unmute yourself. And we have a great question from the audience here. The question is, we have multiple sites and are always short-staffed in nursing homes. We have a lot of temporary, we have a lot of casual staff and agency workers. And the struggle is making sure everyone is aware of all policies and practices up to the same level, especially with high alert medications. What are some ways that you make sure that everybody's aware and follows these practices?
Great question. Thanks, Mike. So we are very lucky at Sienna because we do have multiple venues that we can use to enhance communication. So when we have new hires or agency staff, we have an extensive orientation program that is used to make sure that they are aware of all medication management practices, not just high alert, but high alert is contained in those orientation programs. So they do get that right from the get-go. And how do we maintain that? Because you're absolutely correct. Turnover is a big concern in long-term care. And so we do have, as I mentioned previously, the clinical care partners who are nurses who go in and provide education regularly. So they are in the homes on a regular basis to be able to reiterate some of these things that are new and different. We also have a national DOC and ADOC call. So that's Director of Care and Assistant Director of Care call every other week, where we talk about new and changes in medication management. We often have our pharmacy provider join us on that call as well, and we work collaboratively with them. And speaking about the pharmacy, we do have clinical consultant pharmacists who do reiterate this information as well. So we've got many different avenues, as I said, to be able to make sure that everyone is kept aware and up to date.
It's lots of work in ensuring everybody's up to the same standard.
For sure.
Question for our acute care presenter. And it sort of came through in your topic that developing high alert policies takes a lot of effort and resources. And the question is, what do you convince, or how do you convince leadership that high alert medications are worth spending dollars and time on?
Great question. So as you saw from the presentation, it is an ongoing journey, and the communication to leadership at times starts in showing how you are doing as a care organization with your current, I would say, pulse on patient safety. And so understanding, like I showed with that vasopressin example, on how are we keeping patients safe and what we can do differently to improve safety strategies, really speaks miles to the leadership of the organization, which will support getting those resource dollars, like you mentioned. And I think at my care organization, at least that I can speak to, we've seen that in the growth throughout our 11 years with those continual transformations in terms of being able to support how we use our high alert medications, as well as from a people resource with the establishment of a clinical nurse specialist in medication safety when they first identified needing a medication safety pharmacist. So really ensuring you have the experts in that subject matter content to be able to provide the overview that's needed for keeping patients safe with these medications.
Thank you. And our last question, I'll ask our representative from community pharmacy, and it's an interesting question. It's interesting to me that we can have such careful, exacting policies and procedures related to high alert medications in community pharmacy, but once we give that high alert drug to the patient, anything can happen. It's sort of out of the control of the healthcare practitioner. So what can community pharmacists do to help patients handle these high alert medications safely?
That's a really good question. And I think the best way that I can answer that is share a question that I often get from pharmacy students when they work with me. And what they ask is, could sharing high alert information with patients scare them? Then they stop taking their medications. How do they deal with that? How do we deal with that? And I often provide an answer in the terms of an analogy and explain the best way is to inform them about a high alert, but give them all the information on how to use it safely. And when I use the analogy, I explain with myself. I am not great at understanding all the features of my car. I do not understand all the safety features of my car, but I want to be able to drive my vehicle very safely and transport my children in a safe manner from point A to point B. If I have gotten in an accident and no one explained to me how to use the traction control button on a slippery road, I would be upset. If I had known how to use the traction control button and how to safely operate my vehicle, I would be a very happy person in keeping my family safe. So I think the same theory can be applied. If you give the patient all the information they need to ensure they take their medication safely and not travel down the wrong road and use their traction control buttons when they need it, then they will most likely be very safe and the medication will do what is needed. I hope that answers the question.
Thanks for a great closure to this excellent presentation. And again, thank you to all the presenters, acute care, long-term care, community pharmacy. Really nice to hear from everybody. Again, thank you so much to the audience for participating. Excellent chat going on and Q&A. Again, the link to this recording webinar will be available on the Med Safety Exchange website in a few weeks with links to some of the other websites mentioned and materials offered. A PDF slide is available, or PDF of the slides available upon request to Med Safety Exchange at ismpcanada.ca. Otherwise, everyone have a great summer. Reach out to us anytime, and we'll see you in September.